to since our last session that you wanted to go through?
I don't have any. Ms. Madu, do you have any update? I know Ms. Madu had a patient she presented to you 2 weeks ago, the lady with the CD4 count. So she has an update on that patient.
Sure. If you have any labs or anything, that would be great. And then just for everybody's sake and to remind me, if you could just go through a little bit of the case as well to bring me up to speed. Are you there, Ms. Madu?
She may have to call in also. I see that she is on, but I don't hear her. Let me text her.
Hello?
Yes, hello.
Okay.
There you are.
Okay. So basically, this is the patient who was 41-year-old female who presented for an STD screening, and when we did her lab results, she had the CD4 count of 4. And so we discussed her because we had been trying to get in touch with her. We called her mom in Louisiana. We couldn't get in touch with her. So we were going over what to potentially give to her since she has not been on any medication. She also had Hep B. So can you print out her Hep B labs, the recent one? So you told us to get the full Hep B panel just to see if it was an acute infection versus, something chronic, or if it was even confirmed or not. So we did get her lab results back for the Hep B, and so it did show an acute infection for the Hep B. So
can you go over the specific labs that you got, because it can be actually real tricky to interpret those. So
okay, perfect.
Like
we're about to
surface antigen, surface antibody, those things.
Yeah, the envelopes. We're about to print those out right now. We're just getting on. But I know we discussed, certain medications. At first, we discussed the protease inhibitor-based regimen, this Truvada, Persista, and ritonavir. But the issue was when I read out her resistance test, she was resistant to mostly PIs. So you decided just to do the Stribild, right? Is that correct, to do Stribild because due to the PI resistance? So basically, she finally came in on yesterday. She walked in yesterday or the day before, probably on Tuesday, saying that she had a phone call from her mother, and she was very lethargic. When she would talk to me, she would all of a sudden black out, fall asleep. She was unstable on her feet. Her blood pressure was low. It was like 91 over 50 or 60. Her pulse was really tacky, and she wasn't really there. She was now learning oriented ×3, everything. So I was asking her where she been, why didn't she pick up any of my medications, and she would just black out in the middle of the conversation, like fall asleep. So so basically, I had her stand up. She fell on her feet. We called the EMS for her, and they didn't want to take her at first, but when she started to collapse in front of them, then they took her. Okay. Let's see. So basically, they're saying that she might be septic. She has not been on any medications at all. And so I still sent the Stribild with the azithromycin and the Flagyl, but...
And the Flagyl was for vaginal discharge syndrome, if I remember?
She had BV, she had yeast, so I sent sent that, and I sent the azithromycin. Yeah, I don't know where those labs are. It's not showing up on the computer, but I know it showed an acute infection, but it's not coming up. So I guess we're just going to have to find it again. But for the Hep B was what we were worried about.
And remind me again, Ms. Madu, there were some social circumstances that were pretty major, right? She was still abusing crack cocaine, if I remember? Or?
Exactly. She was still abusing, so I thought maybe she was on drugs, but she said she hasn't taken anything. And my issue was when she walked in here, she had a hospital band on that was dated for last week. So I asked her, did you go to the hospital? At first she said no. When I asked her about the band, she said, oh, I went to Bayshore Hospital because I collapsed in the street. And I asked her, did they even address your HIV, the AIDS or anything like that? She said no. So I don't even know what to believe or anything. We requested medical records, but the hospital is saying that they don't have records of her. So at this point right now, she's still admitted at St. Joseph's Hospital. I have to wait to get those medical records right now, but she's still there since Tuesday. So I don't know what's going on now.
Do you have any contact with the inpatient team that's working her up?
Oh, I have no, not at all. All we did was call EMS, and that's the hospital that she went to. We tried to get some medical records, but they said that she was still in-house. So, but that would be nice to get some information.
Yeah, definitely. I'm trying to find a PowerPoint in my desktop here that I would love to show you. So there's a lot to talk about with this patient as well. The first thing is that, you know, I think I told you last time, when you have people with CD4 counts that are so low, they may feel all right for a while, but I really liken it to walking through a minefield. And, you know, sooner or later something really, really bad is going to happen. And I think you're sort of probably seeing that point right now. She probably looked a little septic, I think, if you said she was tachycardic and had some low blood pressure and was basically proving to you that she was orthostatic by kind of getting dizzy and falling down in your clinic. And it's really, this is where HIV medicine gets really difficult, because you have incredibly large differential diagnosis of what could be happening. And you might say, well, yes, she looks like she's septic, and that's probably the correct clinical syndrome. But what is making her septic? It could be a number of different things. She sounded like she was very dehydrated from what you told me, with a high heart rate and low blood pressure. So she might just have a diarrhea syndrome with chronic diarrhea, where she's losing fluid constantly out of her GI tract and is dehydrated that way. Because she has some central nervous system problems, there's a number of things that can cause CNS infection, basically a fungal meningitis or toxoplasmosis or cryptococcus is one of the ones that's very, very common. And so, you know, when a person like this gets admitted to the hospital, they really should have a very complete workup, you know, to look for all these different things, and see if there's a diarrheal pathogen going on, see if there's a CNS pathogen, see if there's something growing in the blood. And so, like I said, the differential diagnosis gets really, really huge. I was actually kind of surprised to hear that she had PI resistance on her genotype that she sent, but that is the right decision. You need to go with a regimen that really doesn't rely on PIs, I would say, and Stribild is a perfectly good choice for somebody like that. The key point, though, is that if you know that she has hepatitis B, you can't take your eye off the ball with the Hep B. You need to include a regimen that has basically emtricitabine and tenofovir or Truvada as the backbone, because then you're treating the Hep B as well.
Sorry, the Hep B was an HIV patient. That's a whole different story. Sorry.
Oh, okay, so no Hep B. All right. So Stribild, I still would think, is a good regimen for her. Now, there's something specific I want to mention here, which is a syndrome called IRIS, or IRIS. It stands for Immune Reconstitution Inflammatory Syndrome. And it's the one place where you can get into a little bit of trouble with somebody like this who has such a weakened immune system and probably has one, maybe two, maybe even three serious infections going on at the same time. So I would not be surprised at all if she had, you know, a bacterial sepsis-like picture with salmonella or something like that. She could have a diarrheal pathogen like CMV or Cryptosporidium, and then she could have something else like Mycobacterium avium or MAC in her blood as well. Some people with end-stage AIDS have, you know, 2 or 3 or even 4 different infections going on at the same time because they're so immunocompromised that they can't fight anything off, and they get an infection and it just kind of stays there. And not all of them are going to be really acute things. Like, for example, that third one I mentioned called MAC can be a really long, slow, what we call indolent infection that, you know, is with people for a long, long time, not necessarily making them sick right away. But what happens when you give them antiretrovirals is you basically start treating the virus, the HIV at whatever level it is, and I'm sure her viral load is very high. The HIV viral load starts going down, and then as a result, the immune system starts ramping up. And when you have somebody that has maybe 3 different bugs living on them, like maybe MAC, maybe Cryptosporidium, maybe CMV, maybe something else, the person can start to get sicker, actually, and get more symptoms and develop new symptoms that are basically caused by having an immune system given back to them. So it's a little bit of a paradoxical kind of thing. You think you want to make them better by giving them HIV treatment, but sometimes you make them actually sicker by giving them back an immune system. That sometimes happens with people just like this patient who go into the hospital, get sort of semi-stabilized and rehydrated and get some IV fluids, and then get put on their HIV medicines and discharged. They could get sicker within that 2 to 4 weeks after that. So that's an important thing to think about. I wanted to go over, I found my PowerPoint, I think, that I wanted to share with you. And hopefully I'll be able to do this.
She did come in here coughing and all this stuff. Would it have been wrong for us to isolate her because of the risk of like PCP and MAC? She was coughing and everything like that. She didn't have any diarrhea or any symptoms or anything, but she just seemed like she had an infection. So, of course, it could have been with I, but, with her viral load of 4, is it wrong for us to isolate her, give her a mask, or is that pretty much, a bad thing to do?
No, I think that's a great idea, actually. And again, because you have such an immunocompromised patient and you have such a very large differential diagnosis, this could be one of any number of things. With PCP or with MAC, you're not really worried about spreading to other people so much. I mean, it's been described rarely that PCP can be transmitted from one person to another, but what you're really worried about with isolating someone would be TB. And I think, she would have a risk of having TB as well. So sure, putting a mask on her right away and getting her out of the waiting room would be the 2 main things that I would think need to happen sooner rather than later. If you don't mind, let me just go through a couple of slides on opportunistic infections, and I think we'll get to some of the things that I mentioned with this patient. It can get easily overwhelming when you start to look at all these long names of rare infections that you've never seen before, but I just want you to get the general concept of how you approach these end-stage patients with very advanced AIDS. Can everybody see my slides okay?
Yes.
Okay, good. All right, so we'll just do a couple slides on opportunistic infection. So just to keep things grounded in your general understanding, this chart basically shows what happens in the yellow line with CD4 count through time. Let's see if I can get myself a pen. There we go. There's this initial dip that's been described right here where some people with their acute HIV infection can actually have a significant dip in their CD4 count, and that actually happens within weeks to months from acute infection. But then generally they'll kind of come back up here and settle into a new baseline of CD4 count. Keep in mind that a person without HIV, I don't like to say the word normal because I think people with HIV are still normal people, but somebody without HIV infection would have somewhere between 750 and 1,500 T cells. So, I think of a good CD4 count as about 1,000. So they'll have this big dip in acute HIV infection and then reset somewhere around 600 or 700. And then there's basically a long, slow decline downwards all the way down this line that I'm outlining here. Not very straight, but sort of 50 to 100 cells per year that are lost, all the way down to the point where you get into the red zone, so to speak, where you cross over below 200, and that's technically called AIDS, and that's when your risk of OI, or opportunistic infection, goes way up. And the way I like to think about this, let's see if this animation will work here, is that it's like a tip of the iceberg kind of thing. At the higher CD4 cell counts, there's certain things that really all patients are at risk for, and they just start showing up a little more commonly in HIV patients. So TB, you don't have to have HIV to develop TB, but you're just a little bit more likely to get it if you're in that sort of 300 to 400 CD4 cell count range. Things like bacterial pneumonia, this is a question I pimp my students and fellows with all the time. What is the most common cause of pneumonia in HIV patients? And they all come up with, oh, it's MAC, or it's TB, or it's CMV, or it's PCP. The most common cause of pneumonia in HIV patients is strep pneumo. It's regular old bacterial pneumonia. It just starts showing up in these sort of medium-range CD4 cell counts. You can have other things start to show up, like herpes zoster or shingles. In a lot of places that I've been and worked, even in Africa, they sort of start before there was really a recognition that there were a lot of HIV cases, sort of an epidemic of shingles. And it's something that shows up when you have immunocompromised people because their immune system gets weaker, and then the VZV virus that causes shingles or zoster can start to come out more frequently. And then you have other things like HSV, herpes outbreaks, and just general diarrhea that show up at this middle CD4 cell count range. When you get closer to 200 cells, That's when the more unusual things start showing up, and this is where we call these the mucocutaneous manifestations, and that's oral thrush or oral candidiasis, molluscum contagiosum, kind of just an annoying viral infection that causes these wart-like looking things, and then seborrheic dermatitis and eosinophilic folliculitis, just other skin conditions, lots of just sort of strange looking skin things that you're not really sure what they are. And then when you cross below 200, that's when the real big bad AIDS-related things start coming. PCP pneumonia, which is now called Pneumocystis jirovecii pneumonia, or PJP. Kaposi sarcoma can show up. And then as you can see, the further down that I go, the broader the differential diagnosis gets. And I went through some really serious things here, like cryptococcal meningitis, toxoplasmosis, which is a brain infection, some malignancies, such as non-Hodgkin's lymphoma, and then this whole laundry list down here at the bottom: MAC, CMV, PML, microsporoidiosis, and then CNS lymphoma. So your woman that came in with 4 CD4 cell counts, really all of these things need to be on your differential diagnosis, which is why she needs to have a real complete workup, I would think, with a head CT or a head MRI, as well as a lumbar puncture to look for all these things, basically. Here's just another way of looking at things that are a long list of AIDS-defining conditions, and these are kind of agreed upon by the CDC early on to say what is AIDS-related. And they sort of fall into little categories. Some of these things are just sort of general problems here, like wasting syndrome or encephalopathy. Some of these things are actually cancers. So Kaposi sarcoma is a cancer that's caused by a virus, and so is cervical cancer, and so is CNS lymphoma. And then the rest of these things are just other different types of fungal infections, viral infections. TB is on there. Salmonella septicemia is on there, which is something that's more common in HIV patients. So really a huge list of things that could be going on. And interestingly, what type of opportunistic infections show up depend on where you live. So if you're in Africa, there's a lot more salmonella and malaria, and of course a lot more TB. If you're in South America, you have some certain unique things like Trypanosoma cruzi or Chagas disease that can show up. If you're in America, Candida, PCP, MAC, and CMV or toxo can show up anywhere. Histoplasmosis is something that shows up if you've been in sort of the middle of the country, and you guys over in Texas are right in that Ohio River Valley kind of area where histo could be a consideration. In Europe, there's something called leishmaniasis, which shows up in HIV patients. And in Southeast Asia, there's something called penicillinosis, which shows up. And the common picture here is that you become basically a petri dish without an immune system, and whatever local fungus is in the soil or whatever is floating around in the air, you're going to get sick from that. So just think of it that way, that people are very vulnerable and they can fall victim to whatever's around them. Just in terms of general context, there's several approaches that we have to dealing with OIs. You can offer primary prophylaxis to everybody to prevent infection. An example of that would be like pneumococcal vaccination or Prevnar or Pneumovax, giving those to all our patients, which we like to do, or flu vaccine. Secondary prophylaxis is something that we offer only to people that have been infected. So somebody comes in with pneumocystis pneumonia, and then you treat them with Bactrim, and then you put them on Bactrim afterwards to prevent a recurrence. Going back to primary prophylaxis, this is where Bactrim for people with T cells below 200 also would follow under that. Vaccination we talked about a little bit, and then obviously treating the ORI or just treating the HIV, giving them antiretroviral therapy is a good way to prevent opportunistic infections as well. Hopefully you guys know by now the three major thresholds that we use to decide on prophylaxis treatment. It's really 200 CD4 cells right there, 100, and then 50 is the lower one. And the nice thing about this is that the 200 mark and the 100 mark, our main treatment is the same. It's Bactrim or Septra. We're just sort of preventing two different things there, pneumocystis or toxoplasmosis. And then the MAC prevention with azithromycin that kicks in at about 50 CD4 cells. So here's kind of another long list of what we do in terms of prevention. Pneumocystis is probably the big important one. We give Bactrim for CD4 less than 200. TB we don't talk about a lot, but we really should be doing PPDs or what they call a quantiferon test to see if our patients have been exposed to TB. because in an HIV patient, they are much, much more likely to reactivate their TB than people without HIV. And then toxo, I mentioned 100 is the threshold there. MAC 50 is the threshold there. With varicella, HIV patients probably should get acyclovir or immune globulin with exposure for somebody that has known chickenpox. And then the other 3 down there, or 4 down there, are vaccinations. Over on the right-hand side, we don't really have great prophylaxis to use with a lot of these fungal infections, or for CMV for that matter. We don't really give people fluconazole to prevent cryptococcus. That's just because the risk-benefit doesn't really favor giving it to everybody. The one other thing I would mention with your case, Ms. Madhu, is that there is a very easy blood test that you can do to see if cryptococcus is going on, and it's called a cryptococcus serum antigen, sometimes abbreviated as CRAG, C-R-A-G. And it's a very, very good test. If that woman had cryptococcus in her brain, you could pick it up very easily by just sending the blood for that. So I don't want to get too far off track here. We've already talked about the Bactrim here as well. And then maybe I could just go through a little bit on cryptococcus, because I think for this patient that you're talking about, that would be pretty high on my differential diagnosis. Let me get to my cryptococcus slide. I think here we go. So just to review what cryptococcus is, this is a fungus that, it's in the environment. Some of these fungal infections like histoplasmosis have a certain geographical region where they live, and coccidiomycosis is another one that only specifically is found in California and Phoenix. It turns out they're finding it a little bit broader range up in the Northwest as well. But cryptococcus is really everywhere that birds go. And it turns out that certain types of birds, like pigeons, kind of concentrate this in their droppings, so that it doesn't really make the bird sick. It just sort of just spreads it really around the soil. Humans breathe in the spores in the lungs, and so the portal of entry for anybody that gets sick from this is just a spore going into the lungs. And actually a lot of people, including a lot of you listening here, probably have breathed in cryptococcus spores, and since you have a good immune system, nothing really happens. You just get exposed to it, and you fight it off, or you wall it off in your lungs. But in somebody who doesn't have a good immune system, they can't really do that. And the lungs, there's a couple of different consequences. They could actually get sick from their lungs. This picture on the bottom is actually a CT scan from a young woman that I saw in Seattle where her primary disease was just cryptococcus of the lungs. So it can cause a lung infection. But really what's worse is that it can disseminate. And cryptococcus can get into the bloodstream, first of all, and then really go anywhere. On the top of the list here is the brain, because it's the most serious, and it's actually kind of where cryptococcus likes to go. But cryptococcus can go into the liver, into the bone marrow, into the prostate, and cause abscesses. Just kind of can go anywhere. But the most, like I said, the most serious manifestation and the most common AIDS-related manifestation is cryptococcus in the brain, which is essentially cryptococcal meningitis, is what we call it. There are some skin manifestations that can be kind of a tip-off if somebody comes in really sick. And actually, let me ask you, Ms. Madhu, did this patient have anything unusual about her skin at all?
Yeah, I think I talked to you about it before. It was like dark macular patches, and she had little warty-like areas all over her hands and her face. So we were talking about carpopathies last time as a possibility, but she had a lot of, like, some of this looks like it, but other areas were like thick, leathery, dark patches on her skin.
So, yeah, again, it could be anything, really. The things that I would think on the top of the list would be Kaposi sarcoma. She could have a real serious case of molluscum contagiosum, which also kind of looks like these. It's kind of classically described as umbilicated papules like this with a little central dot in the middle. But then cryptococcus and histoplasma both can cause very similar lesions that look like you see on the screen here. And then also common things, just like warts, can present in really dramatic ways with somebody that has so few CD4 cell counts. So that's the kind of thing where, I mean, she probably should get one of those things biopsied to get the real answer. A couple more facts here about Cryptococcus. It was the most common serious fungal infection in HIV, and they say serious because, of course, a lot more people just had thrush, which is just annoying and doesn't usually cause that much morbidity. But in the AIDS era, this paper here is from the 90s here, 6 to 8% of people with AIDS would actually present with Cryptococcus. Much higher risk in people with T cells below 100. And it looks like the peak incidence in the United States was around the 90s. And it has really steadily declined, mostly because of our antiretroviral therapy, and we have less people with T cells below 100. But it's still dangerous, and it's still out there, and it still kills a lot of people. The mortality of a new diagnosis of Cryptococcus is still about 10 to 20%. As you can imagine, in the global HIV epidemic, with all the HIV that's in Africa, the degree of Cryptococcus is thought to be a very large burden of disease, and there's some estimates. I just pulled a paper here that 15 to 45% of advanced HIV in sub-Saharan Africa has Cryptococcus. I worked at a hospital in Tanzania, and we'd have 5 to 10 admissions with HIV every night, and half of them would come in just in a coma, and they didn't really have very good diagnostic ability, so they would just sort of call it coma unspecified, with not really any ability to diagnose whether it was Cryptococcus, but it probably was Cryptococcus in most of those cases. So just briefly, the clinical presentation of this, some of the things you described are exactly the same as I've seen in cryptococcal meningitis patients. It's not a real raging bacterial meningitis the way meningococcal meningitis is, where you have really high fevers and really stiff neck. Only about a third of people have meningeal signs in this disease, despite the fact that they have meningitis. Commonly, they'll just present with fever and malaise and confusion, and this thing you described of kind of going in and out of consciousness is actually very spot on for Cryptococcus. Memory loss, sometimes it might even be a subtle personality change, really kind of a subacute presentation. Very rarely people will remember having a respiratory disease, which might have been the time when the Cryptococcus got into the lungs. And then, like I said, these skin manifestations might be there at the time of the presentation. This just goes to show that stiff neck in this series cited from 1996, stiff neck was only present in 37% of people. So most of the time it's just fever and headache, and then a good third of people had change in mental status or maybe even cranial nerve deficit. And I mentioned this before, the serum cryptococcal antigen is a very, very good test if it's positive, and I would use a threshold of 1 to 8 as being positive, pretty much presumptive evidence of cryptococcal infection. And this is actually positive for up to a month before the meningitis actually develops. So there's been programs in Africa where they just screen people with this test if they have it available. Now, I'm glad that you sent this patient to the hospital, because really what has to happen is a lumbar puncture. And it's not just a diagnostic lumbar puncture, but in some cases taking fluid off and taking the pressure off of the brain is actually what really needs to happen. And I've seen some dramatic cases where somebody looks exactly like your patient that you described, where they're kind of in and out of consciousness and barely awake, and then you do a lumbar puncture and they feel so much better because you can remove some of the pressure. The pathophysiology of this is that the Cryptococcus is a very sugary coat to it, and basically it kind of clogs up the normal plumbing of the cerebrospinal fluid. And so you develop very, very elevated pressures in the brain, and by pulling off some fluid, you can actually lower the pressure in the brain to the point where it's normal, and people's headaches and confusion can actually clear up quite a bit. So this is one case. You probably aren't doing lumbar punctures in clinic, but it's one case where we always train the residents that if you do a lumbar puncture, you have to measure the pressure and get a manometer on the CSF, on the spinal needle, so that you know what the opening pressure is. And that's helpful both for diagnosis and management. There are very few things that are going to give you such elevated CSF pressures, and Cryptococcus is one of them. This is a little more detail than I think we need to talk about here. And then this as well. The treatment for cryptococcal meningitis is here. I think first of all we need to find a diagnosis, because like I said, this could be many different things. Let me just skip through that. So just to summarize Cryptococcus, and we can get back to the case. The classic presentation is a subacute presentation. It's not just sort of a really, really thick with stiff neck kind of person. Usually it's more of listless feeling, headache, confusion, and you may lack the meningismus type signs. or even, I didn't get into this too much, but even you might not even see a lot of white cells in the cerebrospinal fluid if they're that immunosuppressed. The treatment is definitely something that has to happen in an inpatient setting with amphotericin usually, and then this medicine called 5-FC. And usually it's a 2-week treatment or so with that, and then you convert over to oral therapy with high-dose fluconazole. And it's kind of complicated. You do 2 weeks of the induction treatment, and then you do at least 8 weeks of consolidation treatment with high dose, and then you can drop down the fluconazole dose to like a maintenance phase. Intracranial pressure is really a key part of the management, which is why the inpatient setting is so important. And sometimes, you know, people, like I said, the mortality is very high. It's sort of 20 to 40%, even in this era with good management. And the reason is because sometimes there's just too much pressure in the brain, and they either need to get a shunt, like a ventriculoperitoneal shunt, a VP shunt, or they can just die from the increased intracranial pressure. So let me stop that part of the PowerPoint and get back to the case. Any other details that you think are important to share, Ms. Madhu?
Well, it's interesting. You had an earlier slide about the HPV and cervical carcinoma. I didn't think it would be relevant for here, but we did do a pap smear on her that day because it had been, you know, like several years since she had one. She had high-risk HPV. She had low-grade SIL, high-grade SIL, and lesions that they found on the pap. So most likely you think it's cancer.
Yeah, so cervical cancer was actually added to that long list of AIDS-related conditions because it is one of those things that's an infection-related malignancy. And you think about it, it's the HPV that's causing almost all of the cervical cancer that we see in all of our patients. And the same logic applies here, where if you have no immune system at all, the infection is just going to run rampant and have a lot more progression towards malignancy. So that I'm not surprised at all, especially if she hasn't had any screening. That in and of itself is an AIDS-related diagnosis. I mean, she has AIDS already because of her CD4 cell count being so low. But like I said, often you find what they say ticks and fleas. You don't have just one diagnosis going on. You've got probably 3 or 4 in the same patient when they have this little immune system to fight back. So hopefully they'll take good care of her in the hospital. I would recommend that you try to get in touch with the team. You know, they probably should have an HIV expert or an infectious disease expert consulting on the case to sort of direct the workup, because there's going to be, as you've seen, hopefully I overwhelmed you with all these different things, but there can be, you know, lots of different considerations in the differential diagnosis. She definitely needs a lumbar puncture. She might need some pretty sophisticated antifungal therapy with amphotericin if that's what's going on. She may even have a malignancy. In addition to the cervical cancer, she could have a central nervous system lymphoma. And so this patient's going to get really complicated really quick. You know, and she's very sick and has probably a high risk of mortality from any number of these things that could be going on. But I would encourage you to get in touch with them for a couple of reasons. Number one, you can give them more history about her HIV disease and how she presented. You can give them the social history that they might not be able to get if she's kind of comatose. And then number 3, you can learn a ton about this case, and I guarantee you'll never forget about cryptococcal meningitis if that's what she indeed has.
So we're discussing over here. She was sent via EMS. So how do I get in touch with her or this team? Because she's not in the ER anymore, so I can't call the ER doctor to see if she's there. And she's somewhere on the floor, but I don't have, you know, I don't know if I have a right to call and say, hey, I sent you a patient. I know you don't have proof of that, but can you give me some information how she's doing? I don't know how to do that since she's already not in the ER anymore. I don't know where she is.
Yeah. Boy, that's a health system question. I mean, ideally you would have better communication between primary care doctors and inpatient teams across the board. I don't know. I would maybe ask Dr. Eccles or one of your clinic directors how you can increase communication between inpatient and outpatient realm. I think it's perfectly acceptable for doctor-to-doctor communication or provider-to-provider communication regarding a patient that they share. You know, that does not really violate any HIPAA laws or anything. If it's related to the patient's care and you need to communicate with another provider about a patient, that's perfectly fine. So hopefully you'll get a good discharge summary, and you'll find out what happened with her. I'm pretty sure that it's going to be something serious, and like I said, she's got a very high risk of mortality from whatever it is that's going on. And it's unfortunate. Hopefully for all of you that are listening, it should reinforce for you the desire to treat people with higher CD4 cell counts, because it's very sad to say, but all of this, if she does in fact pass away from this infection, this was 100% preventable if she'd been diagnosed about 5 years earlier and linked to care and gotten on treatment. And those of us working in this field that still see this every once in a while, every time we see a case like this, it's used as a motivator to just try a little bit harder to convince that person with 500 T cells to start medicine, or to try to get people to make their appointments and not fall out of care. Because it's really tragic that in this day and age, when we have such good treatments that can prevent all of this, really legitimately 100% prevent it, that we're not implementing things the way they should be. So a good learning case though, and thank you for sharing. I wanted to give everybody else a chance. We've got about 20 minutes left. Are there any other cases from the last couple of weeks that you've seen that you wanted to discuss?
Hello?
Yep, I can hear you. Who's that?
Well, I was just waiting because it was silent, so I didn't hear anybody, so I was making sure it was working.
Okay.
I did talk to you about a patient last week who had a CD4 count of 92, and that was the Hep B that was positive, and you had us order labs on her to confirm it, and I do have those labs.
Okay, great. Okay, so let's go over that one. And if you could tell me a little more of the circumstances of this person on therapy or on treatment for their HIV.
So she's a 38-year-old female who actually came in for another STD screening. She said that she had been diagnosed in the 1990s, and she was being seen at Thomas Street in the past, but she had not been on medication or anything for 6 months. So we did a full, like STD and HIV screening, and her count was 92 or 94, and her viral load was 172,000, and she had not been on any medication for like the last 4 to 5 months. And her Hep B, as far as the acute hepatitis panel, was positive. So you wanted us to go ahead and work her Hep B up, and you discussed for her to do the protease inhibitor-based regimen based on the fact that her genotype was pretty much clear and sensitive, to everything, and we weren't sure about. No, for her, we didn't get a genotype because I didn't want to start her on any medication yet because she had been on medicine in the past, and so I didn't know if she was resistant to anything. So we had to do like a genotype on her when she comes back. But we did get to do the hepatitis B screening profile to find out if she did actually have hepatitis.
Okay, so you have those labs?
Yes. So the surface antigen is positive, and the Hep B core is positive. Core antibody is positive, and the envelope is positive.
Okay. And is that all that came with your panel? Did it come with a DNA or anything else?
No, it just has the surface envelope core. Yes.
Okay. All right, so she definitely has hepatitis B infection. And the nice thing in an HIV co-infected patient is that you're going to commit her to lifelong treatment anyway. One of the issues with hepatitis B that's kind of hard to decide about in a patient that doesn't have HIV is when to treat them, because Hep B is not really curable. Very, very rare that somebody actually will completely clear their hepatitis B. And so for example, a young, let's say 20-year-old dental student or something that has Hep B surface antigen positive, it's actually a hard decision to decide whether you're going to put them on a lifelong Hep B treatment, a pill that they're going to have to take for the rest of their life. So you kind of get out of that decision in an HIV patient because you're going to be treating their HIV for the rest of their life anyway. And it's pretty easy because all you need to do is make sure that your backbone for your HIV regimen has Hep B drugs in it, and anything with tenofovir in it, or emtricitabine or lamivudine, will be treating the Hep B. Just for sort of style points, I would say it's probably a good idea to check the Hep B DNA, and that's essentially just a viral load for the hepatitis B. It is a little more of an expensive test, so actually before you send it out, I would make sure that it's covered or that you're going to get reimbursed for it. I think it's a couple $100. And then there's another set of tests, which is kind of an advanced panel of Hep B. Usually it comes with the DNA and then also something called an E antigen. Or is that what you already gave me when you said envelope? Did it say E antigen, E antibody? Ms. Madhu, are you there?
Yeah, I'm sorry. Talking to you on mute. It says Hep B E antigen.
Okay, perfect. So you got it already. So the E antigen was positive?
Yes, it was positive.
Okay. Okay. So then the only thing really missing is the DNA. And like I said, it's a little bit of a judgment call. If you really don't have the resources to be testing for that a lot, I would maybe do one now and then one in a year or something. But you know, it is our best indicator of whether you're successfully treating the Hep B. So the DNA level, and bear in mind it's a different sort of scale than HIV, so they can be much higher. You can have Hep B DNAs in the 500 million range, and that's okay, that's just the way it is. And it actually does take a lot longer to become undetectable than it does in HIV. But having said that, you're pretty much guaranteed to choose a regimen for her that's going to be treating the Hep B as well. And the reason for that is that all of the recommended regimens, whether they be single tablets like Complera or Stribild or Atripla, or they be combo regimens like, you know, the Prozista, Norvir, Truvada type regimen, they're all going to have activity against Hep B. So you will be treating her Hep B no matter what. Anyway, just a matter of good practice, though, is to get that DNA test before you start, and then follow it every 6 to 12 months. And you know, if it's going to be expensive, I would just say once a year is probably fine. And that Hep B DNA should fall rather slowly. Sometimes it takes up to 2 years to become undetectable, but that should be part of your treatment. In terms of choosing what HIV regimen to put her on, this is kind of a tricky thing because she had been on therapy, it sounds like off and on, and then was off for 6 months, and she's now got a viral load of 172,000. What often happens is that even if they have resistance in the virus, when they're off all medicines, the virus kind of reverts back to wild type. And you might have some resistance that's still there, but it's actually hidden. And so if you send a genotype now, it might just show wild type, and you might be falsely reassured that things are fine. So what we sometimes do is we'll choose a regimen, and we'll put them back on it, and about 2 to 4 weeks later, we'll send a genotype. And the advantage of that is that you're basically putting back some selective pressure. You're taking this huge population of 172,000 copies of virus per drop of blood, and you're killing a lot of that virus and getting it down, and you're much more likely to find a resistant mutation or a resistant mutant with a genotype that's delayed a little bit, 2 to 4 weeks in the future. It's a tough judgment call in terms of what you would start her on. I think all the options are probably available, except I would not put her on Complera because Complera does not perform as well with high viral load patients, and she's above 100,000. But Atripla would be an option. A protease inhibitor-based regimen like Truvada, Prozista, Norvir would be an option. And then as long as her kidney function was okay, I think Stribild would be an option. The way I would approach this is I would put her on one of those regimens, probably either Atripla or Truvada, Prozista, Norvir, or actually even dolutegravir, which is a newer integrase inhibitor, Truvada plus dolutegravir, or Epsicom plus dolutegravir, or the last one I think I said was Stribild. Put her on that, and then 2 to 4 weeks later, check a genotype, just to make sure that you're not treating some resistance that's already there. Does that all make sense?
Yes, because I'm looking at her GenoSure. I guess we did do it. And the only thing that was sent was the Ederant, rilpivirine. It's an NNITI.
Really? Okay. Does it give you a set of letters and numbers, like K1 to 3N or something like?
You mean as far as the mutations detected, or like the
Yes,
whole?
exactly. The actual mutations detected should have a letter and a number.
Yes, it says E138A.
Okay, that's interesting. So that's a pretty rare mutation, but it's a significant one, and I would actually probably lean towards the protease inhibitor-based regimen, given that that mutation.
Okay, so I have a question. Okay, some of them all have mutation detected, but it still says sensitive. So do I go by what is mutation detected, or if it says assessment sensitive versus resistant?
Yeah, what they're doing there is the HIV virus makes a lot of mistakes when it makes copies of itself, and so you're going to get all kinds of different mutants there, but it turns out that most of them don't have any consequences. And what the company does when they get the mutations is they run them through an algorithm. Usually they look at something called the Stanford database, which has all of the really important mutations that have actual clinical consequences. So we know that this drug won't work when you use this, when you use it in a virus that has this mutation. So there's a lot of garbage in there that you don't need to worry about. The printout will tell you only the ones that are significant. So does that make sense? When there's a lot of other mutations that are there that probably don't have any consequences, so they'll tell you the drugs are still sensitive. But for the ones that really matter, they'll specifically say that the drug is resistant, or the virus is resistant to the drug.
Okay, that makes type. And it says something here about a subtype of HIV-1. What does that mean?
Yeah, so there's you're almost always going to see subtype B in the United States, but there are a bunch of different other types of HIV around the world. That doesn't matter too much, I don't think, unless somebody had visited Africa or gotten infected somewhere else around the world. Does it say that it's subtype B?
Yes, I'm looking at everybody's that I have, and they're all B.
Yeah. So almost everybody with HIV in the United States has subtype B. In Africa, it's more subtype C and other types, and then there's even some HIV type 2 in Western Africa that does respond a little differently to some of the treatments. But most of what you're going to see is going to be straightforward HIV type 1, subtype B. So the last thing I would say for this case, and then I'll open it up a little bit more to the rest of the group, is that there's some standard things you should be doing just in terms of her liver health. So you don't really know how long she's had her hepatitis B, and one of the main complications of hepatitis B is liver damage, liver cirrhosis, and liver tumors. And so she should definitely get an abdominal ultrasound focusing on the liver. Some GI specialists would actually push for you to do something more than that, and somehow get a picture of how much scarring there is in her liver. And there's a couple different ways you can do that. The traditional way is to send her for a liver biopsy, but patients don't really like that too much, and it's kind of extreme. There's a couple of newer ways that you can actually assess liver fibrosis, but they're both pretty expensive. So one of them is called a FibroSure test, FibroSure, and that's just a commercial test offered by LabCorp, I think, that, again, it's fairly expensive, and it basically gives you an idea of how much scarring there is in the liver. And then the third sort of cheaper way would be to just run some calculations on her platelets and her AST and ALT levels. And there's a couple different ones that are used. One is called an APRI score, APRI, and one is called a FIB4. And I can email you the equations that you use. You just have to plug them in. Or if you want to give me her labs, I could do it for you. That just takes into account the patient's age, their platelet count, their AST and their ALT level, and tries to guess the degree of fibrosis. And that's kind of important because you... Oh, yeah. So go ahead and give me the labs if you have them. Do you have them now?
Yeah.
Okay. I can't calculate it for you now, but I'll get back to you.
Okay, so she's 48 years old. Her platelet count is 208.
Okay.
And you said you wanted her liver enzymes. They were both 50.
AST and ALT, yeah.
Yes. What else did you need?
Well, just to look at general liver health, I would also want an albumin. which should come with your metabolic panel, and then an INR, which you may or may not have drawn.
No, I don't have those.
Okay. But do you have the AST and the ALT?
Yes, they're 50 and 50.
Oh, 50. I thought you said they were iffy.
No.
Okay.
No, 50.
All right. Okay, so I'll calculate those and email it back to Dr. Eccles with the APRI score. That doesn't strike me as being somebody with a lot of liver damage, though, just based on those numbers.
We did?
But you should, sorry, go ahead.
Oh, we did send her for an ultrasound, but she was a no-show, so I guess we'll have to follow back up on that.
Yeah, you should. There's also one other blood test which sometimes can be helpful to screen for liver cancer, and that's called an AFP, alpha-fetoprotein. It's not very great when you use it on its own, but when you combine it with ultrasound, it can be very helpful to pick up signs of liver tumors. The other thing is that hepatitis B tends to be more of a cancer-causing virus than hepatitis C does. So we sort of worry a little bit more about tumors in the liver with people that have had Hep B, especially if they've had it for a long time. I would try to talk to the patient and see if you know when they first found out they had Hep B. Is this somebody born in the United States?
She was born in the U.S. and she had no idea about the hepatitis B.
Okay. So I would guess that she was infected as an adult, probably, around the time she got her HIV infection. And in those types of people, it's not as worrisome compared to, say, like an African immigrant or an Asian immigrant who likely got their Hep B when they were a child, and then they've had years and years and years of exposure to the virus to their liver, a much higher rate of liver cancer in those types of people. So she probably is going to be okay, but you should just at least think about it and screen her with ultrasound and probably an AFP every 6 to 12 months. All right. Any other questions? I did have a couple more STD slides to show you because I know you guys are seeing a lot of people present with their HIV and concomitant STDs. Speak up if you have any other cases to review. Otherwise, I'll bring up my slides for the last couple minutes. All right, so that's the Cryptococcus one. Let me close that. Here's the STDs. Okay, so I know somebody talked about a case of syphilis last time, and so syphilis I wanted to just go over, and I think I might have showed you some of these slides before. The first thing is that syphilis, before we had penicillin, there was a whole lot of syphilis, and then we kind of got a good handle over it in the United States, but lately things are starting to get a lot worse. And if you look at specific populations, especially men who have sex with men, the rates of syphilis are really unprecedented. They're all going high, and I've seen this in lots of different cities, lots of different counties, lots of different jurisdictions that are all seeing incredibly high syphilis rates. So if you look for it, you're definitely going to find it. I just did this talk for Idaho specifically, and here's some Idaho statistics where you see all the curves going in the wrong direction, kind of straight up towards the sky in 2012. And here's the really important slide that every time you see a patient with syphilis, you should be thinking of where they fall on this spectrum. Is it primary syphilis with an actual chancre? Is it secondary syphilis with a fever and rash and headache, kind of a totally different syndrome? Or is it latent syphilis where there's actually no symptoms at all and you're just picking it up on a blood test? And everybody probably goes through each of these different stages. Well, I take that back. A lot of people here, let me get the pen so you can see where I'm talking about. A lot of people here will start with their primary syphilis here and then skip the secondary phase and not ever get sick. About 3/4 of people will just jump straight to what's called latent syphilis, where there's no symptoms at all. And so you just pick this up by having a blood test like a VDRL or an RPR or a syphilis antibody that's positive, and you have the duty to tell the patient, I'm sorry, but you turned up positive for syphilis. And sometimes they have no idea when the exposure was, they've never had a test before, and you're just kind of like, what do I do with this? The second really important distinction is it less than a year or greater than a year? And that's because you define them as early or late based on whether it's been a year or not. If you have frequently people that are testing frequently, this is easy because you can say, well, when was your last syphilis test? I can tell you right away it was negative until January, and then you had this as positive, so that's obviously early latent, and you just have to give them a single penicillin shot and you're done. But if you don't know, or you think it's been more than a year since they were exposed, and this happened a long time ago, you have to treat them with 3 weeks of penicillin. So it's a penicillin shot once a week for 3 weeks, because that's just really the only treatment that we know that's been tested. Despite the fact that secondary syphilis is a much more dramatic presentation with the rash and the fever and sometimes headache and malaise, people can kind of look really sick. It's just a single shot of penicillin for them, because that syndrome pretty much only, it looks like it only happens in sort of the early type phase, several weeks after their primary chancre. And then just to go backwards a little bit here, what is a chancre? Well, a chancre looks a lot like a herpes ulcer, but tends to be a little bit bigger and tends to be less painful. This is classically a painless ulcer with kind of soft, heaped-up borders. I think I have some pictures of some in a little bit. There's been a lot of studies to see whether expert clinicians are good at differentiating herpes from syphilis, and even the experts are pretty terrible at differentiating the two. So we pretty much always rely on laboratory testing to tell what they are. If you're really leaning one way or the other and it really looks like herpes because it's painful and burning and that kind of stuff, then I would give the person acyclovir. If it looks like it's syphilis and it's really painless, I would give them penicillin, but those would be empiric choices. You definitely need to back it up with testing to see which one it actually is. So here's a chancre. Looks like if that was a herpes ulcer, that would be very, very painful, but it turns out that in syphilis, these tend to be painless ulcers. Here's a couple pictures of rashes from secondary syphilis. It really can look like a lot of different things. This one on the left here you see looks very kind of subtle. It's sort of pinkish maculopapular. And then, of course, the palms and the soles is the hallmark. Not a lot of things cause that. If you see that, you really should be thinking about secondary syphilis. And by the way, these lesions here are full of little syphilis treponemes. So put some gloves on before you touch that lesion. Here's another secondary syphilis rash in the back. Sometimes you can have secondary syphilis rashes that come out in the mucous membrane, and these are called mucus patches. So it can get a little confusing because you might think, well, this looks kind of like a chancre, but it's actually a secondary syphilis rash. Again, this is full of treponemes, and if this person had any oral sex, it'd be very, very infectious. I kind of went over the testing a little bit, and let me just get to the treatment, and then I think we'll finish up. So again, this looks like a big, scary, complicated chart, but it's not that complicated. You put somebody in a clinical stage, either primary syphilis with a chancre, secondary syphilis with a clinical syndrome of fever and rash, or early latent syphilis that's been less than a year, and it's all the same treatment. It's a single shot of penicillin. It has to be the right kind of penicillin. It's got to be benzathine penicillin, 2.4 million units. Or if they're penicillin allergic, you give them 14 days of doxycycline. And then the second, below this red stripe here, if they've had latent syphilis that's asymptomatic, more than a year, or you don't know, that would be called latent of unknown duration. It's 3 shots of penicillin once a week times 3 weeks. Or if they're penicillin allergic, you got to give them doxycycline for 3 full weeks. So we really prefer giving penicillin if at all possible. And then neurosyphilis and congenital syphilis are totally different and much more complicated to treat. So let me get rid of that. I think we're done with our time today. Were there any final questions on the syphilis stuff or any comments on the cases? All right, I'll take that as a no. I think our next engagement, Dr. Eccles, correct me if I'm wrong, I think we're shooting for May 8th?
May 8th, yes. This is Julio.
May 8th is on the calendar. Okay. Anything to add, Julio?
Yeah, I just wanted to let you all know that I'm going to, that we have acquired web meeting, and I'm going to get all the specifics in terms of what that software entails, what its capability is, and then get trained on it. So I think we should be okay for May 8th, even though there's another webinar that's scheduled at the same time through this platform. I can, if we need to, Dr. Ramers, if it's like dramatically different, which I don't think it will be because it's also a product of the same company, if we need to go through a review prior we can set up a half hour, 15 to 20 minutes or so to go ahead and do that.
Yeah, that would be fine.
All right.
Okay. All right, everybody. We'll see you in a couple weeks on May 8th. Thanks for joining.
Thanks.